Hi, I'm Marguerite McDonald with the Ophthalmic Consultants of Long Island, and my topic today is amniotic membranes for severe dry eye and non-healing epithelial defects and for pterygium and pingueculum surgery. Here are my disclosures. So, the ocean panel gave us the double vicious circle model of the pathogenesis of ocular surface disease. So you see MGD on the outer ring, dry eye disease on the inner ring, and hyperosmolarity, inflammation, and apoptosis here on the inner ring. And it pointed out where the various interventions interrupt the double vicious circle. Here you see corticosteroids, lifitegrast, cyclosporin, fatty acid supplementation, and amniotic membrane. And to the right, you see where lubricants, plugs, and perfluorohexyloctane interrupt increased tear evaporation. But we're going to talk about amniotic membranes today. So they are absolutely loaded with anti-inflammatory and growth factors. These are the ones that have been identified so far, but there are probably, almost certainly, dozens more that we have not identified yet. Amniotic membrane has been shown to promote anti-inflammation, rapid reepithelialization of the cornea and conjunctiva with minimal haze or scarring, symptom reduction, corneal nerve regeneration, and infection prevention. So there are currently three types of membranes available. Dehydrated membrane, which is kept at an ambient temperature, cryopreserved membrane, which is secured to a polymethyl methacrylate ring and requires refrigeration for storage, and a lyophilized membrane, ambient temperature storage. So we'll talk about the studies that are already in print on the use of amniotic membrane. As I mentioned, it has several indications from moderate to severe dry eye to persistent epithelial defect, to ulcers, recurrent erosion syndrome, neurotrophic keratitis, and to the far right you see Sjogren's syndrome, chemical burn, stem cell dysfunction. So as far as amniotic membrane's clinical placement, for moderate to severe dry eye, it's usually adjunctive after there's failed first-line therapy or as induction therapy. So for PED, ulcer, recurrent erosion, neurotrophic keratitis, it's usually prior to or in place of a bandage lens. And with chemical burns, Sjogren's, it's immediate. So there are recent clinical studies to support amniotic membrane and moderate to severe dry eye disease. There's one by Thomas John. We'll review all three of these. Dr. Morkin and Hamra, and my study with Dr. Shiha. So Thomas John did a lovely study, corneal nerve regeneration after self-retained amniotic membrane and dry eye disease. It was published in 2017 in the Journal of Ophthalmology. If you look at baseline to 1 month to 3 month outcome measures, pain, speed questionnaire, corneal staining, tear film breakup time, the DEW score, all of them are highly statistically significantly better at 3 months, even though the membrane was worn for 5 days on average. It was not on for 3 months, it was on for 5 days with long-lasting effect. This just shows the improvement in corneal nerve density from the same paper, the control in red, and amniotic membrane study measurement in blue. Huge difference in the density and also corneal nerve sensitivity at 3 months, once again after wearing the membrane for only 5 days. So my paper, verification of the lasting benefit in dry eye, it was a multi-center trial, retrospective, 97 eyes of 84 patients. They had significant dry eye, SPK, filaments, exposure keratitis, NK, chronic epithelial defects. They had failed traditional therapies. Once again, after wearing the membrane for only on average 5.4 days, 88% showed notable improvement of their symptoms, their improved ocular surface, and notable reduction of dry eye severity lasting for at least 3 months. The study ended at 3 months. Who knows how much longer they would have continued to enjoy the benefit. And this is once again from my paper, the same thing, outcome measures to the far left, baseline and 3-month values. And look at the signal, how strong the p-values are. Huge, huge improvements in signs and symptoms after only 5 days. Long lasting. So the T.F.A.S. dues to revised definition of dry eye included neurosensory abnormalities. And Dr. Hamra's paper with Dr. Morkin shows the remarkable impact of amniotic membrane on corneal nerves. This shows patient 2 on the left, patient 9 on the right. Before, these patients had very few corneal nerves. They were distorted. They had nodules on them. After, once again, wearing an amniotic membrane for only 5 days, you see 36 days later, far more nerves, normal morphology, no nodules. Same over here for patient 9, who was even worse off, almost no corneal nerves. This is now 63 days after the amniotic membrane, which was on for only 5 days. And in addition to the morphology, they had improved corneal neuralgia in both cases, in all the cases in their study. Now, this is a study that was presented just a few months ago at the American Optometric Association. This looks at improved best-corrected vision after amniotic membrane. This used the Bioavance 3L amniotic membrane, and it's dehydrated and decellularized, and it looked at post-procedure, post-membrane, best-corrected improvement, and pre to post you see there was an improvement in all patients with an initial best-corrected vision less than 20/25. This is a benchtop study. This was presented at ARVO in 2022, and it was an in vitro test to compare viability, adhesion, and proliferation of human corneal and conjunctival epithelial cells at days 1, 4, and 7. And in all these graphs, the combined corneal and conj cultures are in purple, corneal cells alone are in green, and conjunctival cells alone are in black. So we'll enlarge these graphs and take a look at them. This is the first one, the epithelial cell viability by cell type and scaffold. So we have dehydrated, cryopreserved, and dehydrated decellularized, that's DDHAM. In each case, there was superior epithelial cell viability, whether it was the combined culture, cornea alone, or conjunctiva alone, with dehydrated decellularized amniotic membrane. If we look at adhesion of the epithelial cells on the different scaffolds, once again, combined culture far left, cornea in the middle, conj to the right. In each instance, dehydrated decellularized human amniotic membrane came out ahead. Same with proliferation of epithelial cells. So, once again, proliferation, this is dehydrated decellularized amniotic membrane, and for the combined culture, cornea alone, conj alone, in each of these studies, the decellularized dehydrated amniotic membrane came out on top, and that was the Bioavance 3L. So, switching out of the office, I also use them routinely for Pterygium and pingueculum surgery. Why? The amniotic membranes allow the patient to recover better and faster. They have much lower pain in the early days post-op. There's a publication, at least one, to prove those. The last two are my own personal observations. It allows for a much quicker taper off of steroid drops. We have these patients on a slow taper for months. You can get them off so quickly if you use an amniotic membrane at the time of surgery, and a lower recurrence rate. So, this is a publication by Diaz and his group, Surgical Time and Post-Op Symptom Study in Pterygium Excision and Amniotic Membrane Graft using the Cellularity triple-layer dehydrated amniotic membrane. So this is using large membranes at the time of surgery. And that provides the peer-reviewed proof that I showed you. So a couple of things that I have learned. I use the 15 millimeter circular by F.A.C.S 3L amniotic membrane at the end of the case, and I trefine out a 6 millimeter circle from the center after it's on the eye. I actually don't trefine. I ink up the bottom of the trefine and I touch the amniotic membrane and then cut a little circle. Why do I do that? After I put on the bandage contact lens, which is almost always an 8/8 base curve, they can see amniotic membrane. It knocks your vision down to count fingers. And it's such a big membrane. There's such a lot of the goodies being delivered to the ocular surface. Even if they're missing a 6 millimeter circle in the center, they get plenty of membrane, all the benefits, and the patient can see from day one. So for a few more observations. It doesn't matter where the membrane ends up, as long as it's on the eye. So you put it perfectly centered. If you find it decentered the next day, it doesn't matter. As long as it was somewhere on the eye, it was dumping goodies. And I would ideally like the amniotic membrane and bandage lens to stay on the eye for 5 to 7 days. But because it dumps most of its goodies immediately, the growth factors, within the first 18 to 24 hours, I'm not upset if I take the patch off the next day and out it comes. Usually that doesn't happen, but if it does, I just put another bandage contact lens in without a membrane, because I know the amniotic membrane has already done its job. So this is some surgery, and it's really not edited, so I'm going to drag it forward here if I can. I'm going to see if I can, oh no, okay, see if I can, okay, here we go. Let's get to the interesting part. All right, okay, so that's mitomycin C, and I use 0.04% mitomycin C for 2 minutes on half of a corneal shield. Then I irrigate profusely with 40 cc's of BSS, which you don't see here. Here is the F.A.C.S 3L 15 millimeter membrane, and I pat it down a little bit. Like I said, I'm trying to get it to stick, but it really doesn't matter. And then I take a trefine, and it's inked up, and I make a mark. You don't have to have a perfect circle. You're just trying to get a little window for the patient to see through. It doesn't really matter. So then I get my curved Vanus, and apologies because I did this just a few days ago. And so I start cutting. There it is. Okay. So you could do a square. I mean, it doesn't have to be a beautiful circle. This was a huge 7 to 8 millimeter Pterygium, actually, at the beginning, that was approaching the visual axis. And then I'm just going to pop on the 8.8 bandage lens, and that's the end of it. That's really the end. So this has been a great joy for me. I don't have these post-op patients coming back all the time for IOP checks. I can get them off steroids so quickly. So in summary, amniotic membranes are useful in the treatment of many types of ocular surface diseases, including dry eye, persistent epithelial defect, also corneal ulcers, recurrent erosion syndrome, neurotrophic keratitis, chemical burns, stem cell failure. They're also tremendously useful in pterygium and pingueculum surgery. Less pain by a lot, faster visual recovery, faster taper off topical steroids, and a lower enhancement rate. So thank you.